contraction here, will there be a blood supply here? Will there be a blood supply? So the body has a mechanism at 20 weeks or so, something called secondary placentation happens. In this secondary placentation, the trophoblast invades these smooth muscles. Okay? When the trophoblast replaces the smooth muscle, there is no smooth muscle left. There is only trophoblastic tissue. And there is trophoblastic tissue. Is there something left to cause vasoconstriction? Okay, so this is secondary placentation. It happens in all pregnancies, normal pregnancies. The trophoblast invades the smooth muscle, replaces the smooth muscle, and when the smooth muscle is replaced, there is no vasospasm. There is good vasodilation. When there is good vasodilation, there is good exchange of nutrients, oxygen, calcium, proteins, minerals, whatever you do. All that will happen when there is a good blood supply across the symptoms. When there is no good blood supply, what will happen? Contrary to this, in some patients, see, concentrate. Forget that email business. We'll do that later. We'll leave that later. Okay. We'll do that later. Just keep it. Okay. If the smooth muscle is replaced, there is a nice vasodilated vessel. If there is persistence of this smooth muscle, what is happening? This smooth muscle is going to cause smooth muscle is going to cause constriction. When there is vasoconstriction, the heart, when there is vasoconstriction, the baby will not get any nutrients, isn't it? So the heart pumps harder. Heart pumps harder to open this blood vessel. So when the heart is pumping harder to open this blood vessel, what is the heart doing? It is increasing the cardiac output. Ejection fraction. Heart rate. Blood pressure, guys. Aren't we talking of pH? Okay. So it's going to increase the blood pressure. It's going to increase the pressure because it has to open this blood vessel. So if there is persistence of this, see, if there is trophoblastia, it's called vasodilation. If a few vessels are having the muscle persisting, it's going to cause vasoconstriction. To overcome this vasoconstriction, you need a heart which is pumping faster, increasing the blood pressure, and this vasodilation happens here. So if there is inadequate trophoblastic invasion, or if there is something called inadequate placentation. This is what I want to tell you. Okay? Inadequate placentation, that is, when the trophoblast is not invading properly, then we are going to have muscles persisting in this villi. When the muscles persist, there is going to be difficulty in exchange of fluids. Heart pumps faster, blood pressure increases. That is the mechanism of pH. Alright? Is that understood? Yes, to complicate things, now more vasoconstrictors like angiotensin, epinephrine, noradrenaline, lesser vasodilators like prostacyclin, calcium. All these are less, they are the contributing units to pH. But the main etiology of pH is, what did I tell you the main etiology of prolapse? Yes, what is the main etiology of prolapse? Just now I told you. Alright. Neuronal injury. I was taking inverted commas, I was showing you, right? What is it? Neuronal injury. The main mechanism of prolapse is the nerves of the muscles. Okay, similarly, the main etiology of pH is inadequate trophoblastic invasion. Alright, fine. So along with this, if there is proteinuria, edema is not part of pH anymore. Okay? Edema is not part of pH. Alright, suppose a woman comes with high BP and she has a convulsion. What is that? Now don't call this epilepsy, okay? The other day you people were telling me treatment of, when I asked treatment of epilepsy, you were telling me treatment of eclampsia, isn't it? Epilepsy is a disease which can happen in pregnancy. Eclampsia is a complication of severe pregnancy-induced hypertension. They are two different entities. Understood? Now, eclampsia is generalized tonic-clonic convulsion plus IBP. What is the drug of choice? Tell me. Magnesium sulfate. Okay, what is the regime called? It's called the Pritchard's regime. Pritchard's regime is given 4 grams, don't say milligrams, alright? 4 grams IV in dilution, then 10 grams IV. 10 grams is a high dose. 5 grams, 5 grams. You have to split. You know how much does 10 grams come in? 10 grams comes in 20 ml. 10 grams comes in 20 ml. So 20 ml का एक injection. Can you imagine? Have you taken tetanus toxoid injection? Tetanus toxoid. When you get a cruise, you take the tetanus toxoid injection. How much is the amount? It is 0.5 ml. And after putting the injection, people walk like this. This hand is not moving at all, isn't it? For 2 days, your hand will be like this. You move only the other hand. So you got so much of pain. Imagine how much pain will a 10 ml injection cause in the buttocks. 10 ml. Okay, that's why you should split. So 4 grams plus 10 grams is the loading dose. 4 grams is IV, 10 grams is IM, split it in both the buttocks. So total loading dose is 14 grams. Right? What do you do after that? Yes, any idea? You have to give up? Yes. You have to give a maintenance 5 grams IM 4 hourly. Yes, you got heard of this. Pritchard's regime is very important. The most important regime for the management of PID is called the Pritchard's regime. 5 grams IM 4 hourly you have to give, and this has to be monitored with the urine output. Yes, what else? Yes. Albumin. Proteinuria. BP. Knee jerks, यार मैं K लिख के J लिखा हुआ था. Knee jerks. All right, never mind. You've not heard of this. All right. Urine output, knee jerks, and respiratory rate. If the output should be more than 100 ml of urine in 4 hours, knee jerks should be present. Respiratory rate should be more than 14 per minute. Then you will give it 4 hourly till 24 hours